Welcome back, everybody. Welcome back to the afternoon session. It's my great pleasure to welcome Professor Bo Jacobsen. Bo is the FIGO Division Director of Maternal and Neonatal Health. He's a leading expert on the mechanisms and the epidemiology of preterm birth. His research group is the world's leader in the genetics of preterm delivery and the timing of birth. And his main research aim is to identify and apply different strategies to prevent preterm birth to improve clinical outcomes of preterm-born children. He's published over 370 peer-reviewed papers in leading journals. He's been involved in the work of different international maternal child health organizations for more than 20 years. He co-leads the Maternal Neonatal Child Health work stream in the Partnership of Maternal, Newborn and Child Health. And he co-edited the Born Too Soon, the Decade version. So many of you will have seen the most recent data about preterm birth, so he was involved in that. And he's co-chaired the Global Advocacy Group. And he's going to be talking today about Born Too Soon, from basic genetics to global health for reduction of preterm birth. Thank you very much, Bo, for coming and talking to us.
Thank you. So thank you very much. It has been a very engaging morning here. It was fantastic to be here and lovely to see you all here. My aim is to come to this Born Too Soon report, but I believe it would be more effective than you believe me to be a global health guy, to start with what I've really done from the beginning in different ways. So I will speak to you a little bit of the situation from amniotic fluid, from genetic discoveries, and coming up with a public health global report in the end to do this. Instead of doing a total global health kind of talk, I think that this is more effective, because that is the low-hanging fruit, even if it's massive intervention that we need to do, but we need to come together in advocacy. And it has been so good to be here at the Institute today and see how all the professionals here in this area and also in the other where you're streaming this is coming together, and also digital on the web, coming together with different professionals and coming together and build a team around this, because that is the road forward. And it's not only enough taking up the science. We need to be a part of the programming, making it happen in society, and also do the advocacy and help the patients to be the voices. It's so much more effective when the voices of those that really, these concerns in really than our kind of health professional perspective, of the biological perspective of this. But let's start with amniotic fluid. We have published some 100 papers, more or less, describing the situation in amniotic fluid and in fetal tissue and in maternal blood in relation to different kind of threatening preterm delivery. And we have come up and confirmed what others have shown before us, that it's an ascending infection coming up the uterus, causing inflammation, causing harm to the fetus in different ways, and also very few of them have a clinical choriamnitis. What we have contributed with and continue to work in is that we also found out that sterile inflammation is really a part of this, and that damage-associated molecular patterns are part of creating this inflammation, and that is a different method, and antibiotics will not be able to do anything about that. We have also learned during this journey, Professor Raman was my first PhD student, and he really developed fantastic things before and after his thesis, and he has shown that PPROM, rupture of membranes, preterm, pre-labor rupture of membranes, has really partly a different story than preterm labor, in the sense that senescence, the aging process, and that the membranes are affected to senescence mechanisms in different ways to kind of weaken the membranes, thinning in the membranes, and then finally rupture the membranes. And that the infection is really a secondary part in this, rather than the kind of primary part. Of course, there are different for PPROM as well, infection can be part of it, but it seems that the senescence, the senescence of the fetal membranes is really the first aging signs that it's really weakening and rupture these membranes. Another of my PhD students from Czech Republic, Marian Kasarovsky, we have continued to do this. I don't do the amniocentesis on threatening preterm labor any longer in Gothenburg, but we have done it massively in the Czech Republic in different ways due to his organization skill and leading a major delivery unit there. So we have done amniocentesis on PPROM, PTL, and we have also done repeated amniocentesis in women with threatening preterm birth. And that makes possibility to follow up and see what happens with different kind of treatments. And we have seen that this kind of triple antibiotic regimen that you find down here in the right corner of that picture is able to reduce the intrauterine inflammation and even mitigate it so much that it more or less disappeared, both in PTL, also in PPROM, but also in the other phenotypes. Normally we have been speaking to PPROM and preterm labor so much, but we have also focused on threatening abortion, where normally, and that there is where it's so important that we don't split in different subspecialties of gynecology and obstetrics when it comes to women's health, but really work together, because it turns out that these antibiotics can really, if we do amniocentesis and threatening late abortions, we can find out that some of them are really driven by infections, some are driven of sterile inflammation, and we have shown that you can prolong these pregnancies to term and having a healthy baby instead of a spontaneous abortion. And we have also some preliminary data on that statin can be of much use when antibiotics doesn't really work there. So there are progress in this field. However, it's amazing to have both Peter and Neil here, and we are concerned, of course, about the kind of outcome of the babies that have been exposed to this inflammation. And we know from the Oracle trial and other trials that it might affect in the long term. But in one of these studies that we have recently published, it is at least that we have a baby born at term instead of having a spontaneous abortion early. So things are developing here, and we have much more to learn. But the first part after my thesis were done, I was at the crossroad where to proceed to be able to study mechanism of preterm delivery. And we know that parturition might be initiated by different kind of pathological pathways. Some of these are part of a physiological timing process, and other may override those maintenance mechanisms, like the case in uterine infection. And one of the significant obstacles to making progress in understanding human pregnancy is the lack of relevant animal models. Unfortunately, this limits our abilities to extrapolate from animal models to human pregnancy regarding things like the pregnancy length. So we were at Crossroads. We published a model together with Henrik Hagberg and Carina Mallard at University of Gothenburg to be able to study this in mice and rats. But in the end, we decided, due to these obstacles, to go to genetics instead. And one of the things is that few things have been so kind of brutal, like the ultimate consequences for the mother and baby if the mother is not able to control the gestational age, gestational length in a way. Because if the baby becomes too big, it will kill the mother and it will kill itself in that sense. So it's really a kind of ultimate evolutionary axe in this sense. So with this background of the obstacles during the kind of extrapolation from animal studies, we decided some 20 years ago that we will study genetic variation in humans instead, to look at that as a kind of experimental model to be able to identify mechanisms that are related to normal control of parturition and also in general, and also preterm delivery in particular. And we decided to do that when this kind of genetic revolution came up, that we were able to study single nucleotide polymorphism and having better kind of way of doing. So we were really there from the start in 2003, 2004, and it turned out to take 20 years really for us to do this. So SNP or the polymorphisms are simple concepts. SNPs are the places in the genome where we as people differ, except for the X and Y chromosomes. It's one in about 1,000 letters that code is a SNP where you might have a C and I might have a T, and those are the genetic part that makes us look different, appear different in many ways. But some of the SNPs might be aggregated in cases and not in controls, and therefore confirm a risk for diseases like diabetes, inflammatory bowel disease, preterm delivery. And the SNPs are the intense current interest because they might tell us about diseases. So we are interested in to find if they are enriched in cases or in controls, and do and infer different kind of conclusions from that, or experimental things. And they are common variants that we have been studying. So they have, all of them have small effects coming together and might have a more big difference. So in 2008, we have a genome-wide association studies on preterm delivery from different Nordic cohorts, and we had 8,000 samples. And it turned out that we didn't really find anything. So that is a Manhattan plot you see there, and a significant level should be, in these kind of studies, 5 to the 10th of -8, and it was far away from there. So we had spent a lot of money to do this genotyping, but it has not really succeeded. So we continue to chase new samples, and we also looked into the phenotype, because the phenotype of preterm delivery is really a difficult one. It's a syndrome of syndromes. It's not simple, and it's a time length. And if it's a time-defined phenotype, that means that there are many, many simple reasons to have a preterm delivery, like kind of a consequence of a previous DNC, or that malformation, or having one of these syndromes like PPROM, like PTL, like preeclampsia in different ways. So we decided also to use the continuous gestational duration as one of the possibilities to study. And after a while, we collaborated with one of the big genotyping companies, and we were able to get a rough phenotype of gestational duration from maternal estimation, but having good replication cohorts. And we published the first 8 genetic variations that were related to preterm delivery back in 2017. And last year, we published the follow-up study on that in Nature Genetics, and we found some 25 genetic variation on this. And I will not go into those details here today, because the lab work, we have done part of the lab work to try to understand which is the causal variant and how it works, and we have some data on that. But one of the things that were also confirmed by this study was that we were able to, because we had trials, we had maternal father and baby, and we could look at who is contributing to the genetics of this. And it was obvious that the mother needed to control gestational duration. So it's more or less only inherited on the maternal side, but when it comes to the size of the baby, it's much more, the father has influence in this. So the maternal genes are on the maternal side of the pregnancy, not on the fetal side, is the one that is really controlling gestational duration and preterm delivery, to be able to get control of it. But it's so, the evolutionary pressure on how this has been controlled is so interesting. So that genetic variant that reduced the maternal gestational duration is also have an effect on the paternal side, on the fetus, on the paternal side on the fetus. So it really makes the baby a little bit bigger. That is a kind of sign how influenced these kind of genetic evolutionary acts has been in this sense. But it's a very high-hanging fruit. I will not see the kind of clinical implications of this, but there are low-hanging fruits, how we can come together in different ways to really be able to do that. And I had the opportunity to be working with FIGO, the International Federation of Gynecology and Obstetrics, and we were at the PMCH, the Partnership for Maternal and Newborn Health meeting in Hague 2019, and we came together with some of those have been part of the first report and really pushed through the system of PMCH that we needed to have an update of this and follow up. And we have been working on it since, and it still takes a lot of my time. It has been fantastic to be here. And we launched the report a year, 1.5 years ago, but we are now doing a series in the BMC reproductive health to also reach out, to be able to reach out to the scientific community in different ways. So we were a core editorial group. I was working with Etienne Langos, with Anna Grunding, Mary Kinney from University of South Cape Town, but especially here from London, also Joy Lawn, that have been heavily involved in this and have been also part of the first. And we also worked on with the Global Advisory Group, and we also had advocacy and communication group. The outreach from Cape Town 2023 was 250 media products across all 6 continents, and the total estimated media reach out were 3.5 billion people. So it really came through. And the story was, it has not more or less happened anything. Still 1 of 10 babies are born too soon. Still 30 years later, neonatal disorders, preterm delivery is causing the most kind of disease burden in the population, and it has been quite substantial. And of course, it's Southern Asia and Sub-Saharan Africa where everything happens. So 3 million babies in India is born preterm every year, and quite similar in Africa as well. So it's mainly there. 13.4 million babies are born preterm. And from my perspective, from my professional obstetrics, that is normally how should we solve this? And in the obstetrical community, there is a huge discussion regarding progesterone and cyclage. Will this solve this problem? No. And I'm quite upset. I think that I ended up here listening to some from London, some from other people from some universities in US. They never talk about that this doesn't solve the problem. We published a paper in one of the PLOS journals. It was very rapid to get it out, so it was there. And here is a summary of the population attributable fraction from the different risk factors or the interventions that we are doing. And the kind of cyclage of progesterone has a tiny, tiny, tiny effect on the population level. Tiny. It might reduce, vaginal progesterone might, in cervical, in short cervix in women without symptoms, have 30% reduction. But it is on how common is that phenotype? It's very uncommon. That means that the population attributable fraction is extremely low. But look here, this is from Sweden. One of the highest women's education societies where women have most education. Still, it's 0.4% that can come from improved education. And you see the big thing is nulliparity. the risk at nulliparity. We can't do so much about it, but there is, if I would have been 25 years or 30 years today, I would work there. And also the genetic data, what I showed you before, it seems to be mainly working in nulliparity. So that is a little bit the story. So how we should work on this, we need to come together. It's about universal health care, it's about primary health care, and it's about how we build the society and how it works. And we who have this kind of understanding and knowledge, we need to step up, and we need to be the global leaders in this sense, and also build on some of the things that we heard here earlier today, how we should work. Here is the content of the Born Too Soon report, and we had a new chapter on the rights and respectful care, putting people in the center of the response to preterm birth, and also we had a new chapter on intersectorial excellence, integration of the impact on preterm birth. And it has been so nice to be here today and look at how important it was. Even if I'm obstetric and gynecologist, it was by going through this process, one of the most important thing was to get aligned again with the anti-conception and abortion, women's rights perspective. That is so important. The wanted pregnancy is the safest pregnancy. It's one of the most important things that is much more important than the séclage and pessary, to be able to control the fertility and a wanted pregnancy and avoid the teenage pregnancy. And we have kind of positive messages. This is from the maternity chapter that I, of course, was involved in, but also how we can work with reducing, this is a country snapshot, you can't read this, but you can see the figure that teaching about comprehensive sexuality education in Zambia reduced the teenage pregnancy, and that is something that really mitigates. And also spread the knowledge that we have regarding antenatal corticosteroids. Here is example from Cambodia and Philippines that we give examples, and that is things that we really need to do. But the two priority tracks are prevent preterm birth and women's rights. It's part of that, in the middle of that center. It's not only progesterone and séclage, it's about anti-conceptions, it's about family planning, it's about antenatal care and childbirth under safe circumstances. It's about managing. We know about the antenatal corticosteroids, the magnesium sulfate, and some of the antibiotics, but also spread the other track with improved neonatal care, especially on level 1 and 2. There are few babies in comparison globally that needs at this stage level 3, so 1 and 2. We can do the PrEP 5 that we have produced a paper on. It's antenatal steroid, magnesium sulfate, it's breastfeeding, it's about immediately kangaroo care. Immediately kangaroo care reduced neonatal mortality with 25% in middle-income countries. No genetics will ever do 25 reduction, to be honest. So there is a lot of things that we can do. And we can collaborate with the PMCH, WHO. They have, of course, very well access to political leadership, and we can help the leaders in this difficult world now with a lot of conflicts and wars. We can still help that it's a good investment to calling leadership for action from top down, but also from the patient's way up. And we are poised to act. We need to invest, a kind of investment in maternal and newborn health is an effective. Something like 1 to 10 is the kind of revenue if you do investments in healthcare, and not having people standing on the side of the road. Here is from the US, having a sign, I got a preterm baby, I need money to take care of them. We need, primary health care, and that is very much highlighted in this report. We need to implement in partnership with women and families adopting right policies is necessary, but not sufficient. We need to come to action. Many countries have kind of already adopted the policy that it needed, but we need to take actions. We also need to integrate with other sectors within the society, and finding possibility to work with equity and rights. We see it on the wall here. I'm very impressed of this building, even if I heard that you're longing for another building, but yeah, this sign, the writing here is very nice. Economics, education, and taking care of emergencies. And we need to innovate as well. And we also need to do implementation research. I've heard that from many speaking here today. We don't need only to do some genetics, we need to do implementation. How do we take action? And there are huge kind of low-hanging fruit that we can pick here. So the big picture, how can a professional organization to get there? We need to engage in global health leadership. We need in the professional organization to come together and train senior doctors and also young to come up, and both in maternal health and also within sexual reproductive health. And I see the kind of perspective that you have here at UCL, working on different issues, coming together, because that will make the difference. And we need to stand unified in and non-hierarchical in the kind of on the globe for the global maternal issues. And we shouldn't only do the guidelines. A lot of clinicians are very happy to do different kind of technical guidelines, but it's not enough. We need to make sure that these technical guidelines are implemented. We need to work in programmatic work, and we need to come together also and doing advocacy together with patient groups in different ways. And here is a picture from the global leadership program at FIGO 2023 in Paris, with representation from Pakistan, from India, from UK, from Bangladesh as well. How barrier assessment, going from technical guidelines to programmatic work, how could we reach out, how could women get hold of this? And we need to do a joint huge effort on women's and children's health, working together with government, healthcare professionals, and parent organizations. And here is a little bit part of my family as well. Yeah. And
Thank you, Bo. I'm sure we've got some questions in the audience. Does anybody like to ask Bo a question?
I was too engaged.
I mean, I think you're absolutely right. We're thinking about this in the sort of Tommy's preterm birth centre, where it's clear that it's not just about short cervixes. So you're saying if you had your time again, you would focus on the first pregnancy. So challenge, what would you do? Before the first pregnancy, perhaps.
Before the pregnancy, yeah. So there are many different things, but I think that we can learn a lot from what is needed in the first delivery in different ways and how it works. And also we need to work in public health related to this as well. And also before pregnancy, I think that it was obvious that I promoted women's reproductive rights here. I would be interested in the cervix, to be honest. Yeah, and the inflammatory process in relation to that, and also how this delivery process may happen. I will be a lot at the lab, I believe, together with this kind of implementation that we can do. But cervix is one of the things.
Yeah. Fantastic. So anybody want to make an impact in preterm birth? There you go. Are there any questions out there? I'm sure there must be. Yeah. Oh, there we go. So Owen, over to you. Yeah.
Have you replicated your genetic studies in non-European populations?
That's a good question. That's a good question. So we're having, because that is where science are right now, because most genotyped patients are in Caucasians. That's it. So we are doing this right now. If we manage to get the data from 23andMe before they crash, and it's very, but they have been very collaborative. So in the next step, we had 250,000 mainly white women, but we also we are waiting for those data. Everything is ready. We have been waiting for a year more or less, but it seems that we are getting it soon. And the other thing is also that Gates has sponsored, so I've done that work together with Lou Muglia and Gia Sang in New England Journal paper. They were leading. We led the Nature Genetic paper, and they have done a Gates study, and we have representation from both Pakistan, India, and Bangladesh, and from Africa as well. So we have some own data, but we need to have that, and that is a problem because the most genotyped, the majority of the samples in our came from the Nordic countries. But yeah.
Watch this space. Raf at the back, yeah.
Thank you. I cannot not ask the questions around the cervical length. So how do you think we can lobby founders or governments in a different way? So randomized trial on cervical length, especially in the first pregnancy, all negative or controversial. However, in countries where Israel or the state of Victoria in Australia, where they introduce universal cervical length for primi gravida, they show the drop in the preterm birth rate in many years of observation. So many times we are asked to answer a research question in the wrong way, I think.
Yeah, I'm not convinced about, I think that Israel, when they decided to do that, they should have done it in a step-wedged way, so we can follow that in a way, so we can be sure that that was what happened. They state that, and the problem in preterm birth research as well is highly, let's say, political. They published that in White Journal, and I don't know if one of the editors. They don't only want one story; they want a positive story. We had doing our kind of studies on cervical length measurement, intra and inter and intra replication rate, and it was tentatively accepted because it was not making that story positive, because it was so difficult to measure cervical length at that state. It ended up that they reacted that, but when we come back with a positive story on progesterone and cervical length measurements, it was accepted like that. So there is a community out there that is over-enthusiastic about cervical length measurements and vaginal progesterone. It works. Yes, it works, but maybe not as good.
Yeah. Martin, last question.
Very, very interesting talk. Can I just ask, if the cervix is such an important aspect and the genome and the environment play a key role, why not studying the epigenome in cervical smear samples predating the actual pregnancy? And you have a very young population. There are 1 or 2 countries who have population-based cervical biobanks, and you know the outcome. So this would be, in my opinion, the next step to take.
Thank you very much. I believe that epigenome is very important. I also see the cervix as the kind of, it's the thing where things happening in different ways. We also have been studying, so another kind of area here is that we have done all these studies on the intraamniotic infection inflammation, and we have been able to see that those are conization. It published in the American Journal a year ago. They have much more infection and inflammation. So when you have been operated in the cervix, there is a lot of more things going on. So that is another direction I would go.
Fantastic. Thank you so much. Please thank Bo for a wonderful talk. Thank you. So I'm now going to hand over to Professor Melanie Davies, who is the chair of the EGA Hospital Charity, and she's going to introduce our EGA Hospital Charity presentations.
Great, thank you, everyone. So, just to introduce the next session, the EGA Hospital Charity. For anybody who is new to the hospital or new to the Institute, this is your local charity. Elizabeth Garrett Anderson, on the left of the screen there, a picture taken from one of her portraits, was, as I'm sure you know, the first woman to qualify as a doctor in the UK. She set up a dispensary for women, which became a hospital for women. So women patients, but also it gave them for the first time the opportunity to choose to be treated by a woman. That hospital grew and flourished and took her name on, and was actually situated in the Euston Road down the road for almost 100 years. It came under threat in 1979. There was a public outcry and a campaign to save it. The hospital did continue, and the funds that were left over from that campaign founded our charity. And we've still got the same mission to improve women's health. We provide equipment, furnishings for the hospital, training of staff and their support, and also, importantly, for this audience, we give money to research projects and innovation. And if any of you want to scan that QR code and donate, you'd be very, very welcome. So the things that might be of particular interest, and to lead me into our speaker, are that we regularly run calls. The Innovation Fund for the hospital ran about 2 weeks ago, so some of you in the room may have contributed to that. We had some fantastic preservations for quite small sums of money that can really transform patient care. So, I mean, for example, the fetal medicine ceiling lights have been a great success, so that when women are having invasive procedures, they're not just looking at a fluorescent strip light, but they have something more pleasant to focus on. We've done videos for patient information and so on. We also regularly run a travel award. So for any doctors in training, it doesn't have to be doctors, but anyone who wants to travel in order to extend their career experience and training, apply to our travel award. And the EGA Charity Research Scholarship, which is newer, it's been running now 3 years, we're about to open the 4th call. So applications are welcome for the next month, to the end of January, and one applicant will be chosen who will have their PhD fees funded for the duration of their education. So today we're going to hear from one of our successful award winners, and that's Jennifer Davis Oliveira. If you want to come up, Jen. So Jen won the Travel Award and travelled to Kenya to do a project about self-sampling for cervical screening, which she will tell us about.
Thank you so much for the invitation to speak. I'm going to talk to you today about some of the work that I've been doing, both in my PhD, but also as a result of this as I received in this generous award, was able to go to Kenya and do some work out there, collaborating with some colleagues in this area. So this is going to be on self-sampling for cervical screening in Kenya. So a bit of background, I'm sure you all know it, but cervical cancer is caused by high-risk strains of HPV, specifically an infection that persists. However, of course, we know that HPV is super common. We all probably get it at some point, but clear it. But in a small number, unfortunately, that does persist and causes cancer within 15 to 20 years if immunocompetent. Unfortunately, just like all health conditions, it does represent a health inequity, and unfortunately, the burden of cervical cancer is within low and middle income countries, specifically within sub-Saharan Africa. There's a lot of work to be done, and because we've got fantastic tools, so vaccination, the HPV vaccination, which is amazing and a game changer in this sphere, and cervical screening, we could eliminate this disease. And the WHO, just prior to COVID, essentially launched their elimination campaign with quite high targets to reach, so 90% vaccination coverage, 70% of women being screened at least twice in a lifetime. And of course, we also need treatment, so that's also important. Now, we know that cervical screening does save lives. In the UK, when it started in the 80s, we've seen a drop of about 70% of individuals actually getting cervical cancer. So it does work. My talk is going to talk about cervical screening rather than vaccination. So, what's the current state of cervical cancer screening and management, both within the UK and Kenya, just to set a scene? So there's quite a big disparity between screening coverage, as you can see, and also testing methods. So there's quite a few testing methods in Kenya that are still being used. And in the UK, in 2019, we moved to HPV testing, although saying that Northern Ireland has just switched to HPV testing. And we've done it because we know that it's far better, so it's far more sensitive to detect high-grade disease, which is what we need to detect to be able to treat and then essentially stop cervical cancer developing. So, but in Kenya, they use cytology still with varying degrees of sensitivity because it's very user-dependent. They do use HPV in some places, but you do have to pay for it. And they also do visual inspection for free. So this is when essentially you have a speculum examination, you look at the cervix, put a CETA white on, and decide whether they've got a lesion and treat it either with cryotherapy or cold coagulation. So lots of different methods and varying degree of cost to the individual. We're very lucky to have the NHS here because obviously we don't have to pay for this. So barriers to screening within the UK mainly are around access, having to go to a GP to have a speculum examination, and the embarrassment and the fear/pain of the speculum examination. And these are universal barriers in Kenya too. However, the cost is really an issue, and there's a huge fear around what may be found. There is more, but my slide doesn't seem to be. Anyway, at the bottom was the key bit around self-sampling. So self-sampling has now been developed, and that's because we now utilize HPV testing as a primary test. And HPV can be picked up in vaginal mucus with a vaginal swab. Super easy and very acceptable. A lot of people call it like a COVID swab for the vagina. Which it pretty much is. And essentially, in Kenya, this is actually available to people, but they have to pay for it. In the UK, it isn't available on the NHS screening program. You can pay for it here as well. However, obviously, it could really increase uptake in, the uptake, especially in Kenya, but also within the UK and non-attenders, because it may be more acceptable. It probably is. And it breaks down all these barriers that I've spoken about there. However, vaginal self-sampling doesn't seem to overcome all barriers because, unfortunately, in the UK, in most studies, the uptake's only been around 8%. However, there was a recent study, UScreen in London, which asked those that actually didn't attend for screening to try a vaginal swab. And if it's offered opportunistically to individuals, they're more likely to pick it up. So 1 in 2 individuals would return a sample. So that's really encouraging. However, because it didn't meet all the barriers potentially, we were very interested in looking at urine. So my whole PhD looked at urine HPV testing as an alternative sampling method for cervical screening. So I went to Manchester 4 years ago and fell in love with this device. It's called a Colli-P. We have had a tumultuous relationship. But essentially, this is a first void urine collection device. It's super sleek and it really works. And it actually means, and I'm sure everyone in the audience may know, that you don't get urine on your fingers when you do a urine sample. So it's got a funnel, which is a good shape. Essentially, you need to get the very first part of your urine flow because that essentially is pushing that little bit of mucus that's on the urethra that could have HPV into the sample for testing. So really important to get the first part of the urine. So this is a device that we were very interested in testing within a UK population. There was some work in Belgium already. Obviously, it's super acceptable. And so we wanted to really delve deeper into this for test accuracy within a colposcopy high-risk population and also a general screening population. And that's me demonstrating with a bottle of water above. So what happens is that you get the very first part of the flow, it goes straight into that tube and it mixes with a preservative, super important just to fix that DNA. And also that little stopper comes up and the rest comes out through that front bit. So it's really quite a neat device. However, let's just go to the next one. So these were the aims. So how good is it at picking up high-grade disease? Is it acceptable? And can it encourage people to attend cervical screening? So we did a cross-sectional study. Essentially, I collected a lot of urine from colposcopy clinic and a lot of smears later. And I was really interested as well in seeing whether this device was actually was it better than a sterile pot? Because sterile pot is super cheap. And if it's the same in terms of accuracy, why do we need to use the Colli-P? So 500 people later, and also in a primary care population, looked at as well. So it's a different population, less risky in terms of HPV rate. And we wanted to really see how acceptable was it and how good was it at picking up those with disease. So this was published in BJOG earlier on in the year, and as you can see, the Colli-P outperforms the standard pot quite significantly with a relative sensitivity, so that means how good it is by comparison to a cervix sample of 0.92, which is non-inferior, which is super exciting. And in a general screening population, we found the specificity to be 0.97, the relative specificity, which is also fantastic. So really very positive results. We're really excited about the potential to have another sampling option for individuals who need to screen. Very acceptable, with almost 3/4 of those saying that they somewhat agreed or strongly agreed that they would be happy to be screened with a urine sample in the future. So we're doing a couple more studies looking at whether it improves uptake in non-attenders, so offering different things, a bit like the UScreen study, and also people can just ask us for a pack and we'll send one. So if you have anyone who you know, you're very welcome to get in touch. So all of this came to a point where then somebody from Kenya, Lois, got in contact with Professor Crosby, and essentially we started a collaboration around bringing urine sampling as an option for cervical screening in Kenya. So that's some lovely photos of us in Kenya on a veranda. But also Anissa there is this incredible gynae-oncologist working in Mombasa on the coastal region of Kenya. And she also collaborated with us. She's holding a Colli-P. She's equally as excited about a Colli-P as I. And also some incredible professors from the University of Nairobi and, of course, Professor Emma Crosby. So we wanted to see how acceptable self-sampling methods would be within a Kenyan screening population, but also to healthcare workers, because healthcare workers and their opinions are very important and taken into account, and that can really break or make an intervention. And we were also really interested in different areas of Kenya, because Kenya is huge. So we wanted to see what opinions were around Nairobi and also Mombasa, the coastal regions, so 2 different regions. Was it acceptable, vaginal and urine self-sampling, and whether they would address barriers in Kenya? So I don't have all the results in terms of the fact that we haven't looked at the results in great depth, but I'm just going to give you a little flavor of what we found. But we went to this region in Kenya just south of Nairobi, and this is a county hospital, and we interviewed 5 staff. This was Alois and myself, and also 24 women in different focus groups. And the main barrier was around what the test may find. So one woman said, everyone who has had cervical cancer screening has died. And that's because it's not used as a screening tool, it's used as a tool for individuals that are symptomatic, so they've already got disease. So, and the other issue is they call it cervical cancer screening, which I just think is kind of, is misleading, because we're not looking for cervical cancer, we're looking for a precancerous process that we can treat. It's costly, and even though visual inspection is free, it still utilizes a speculum, and nobody wants one of those. Trust in the healthcare worker. Interestingly, they talked about younger healthcare workers, not trusting them, and also something there about a speculum examination being, not acceptable. Went to the coastal region, which was a little hotter than Nairobi, very beautiful, and went to a couple of hospitals there, interviewed some more staff and did focus groups, very similar to the other, just to see whether there was a difference. Essentially, I'm trying to read the slide because it's very much changed from the original. So the infrastructure's a problem. So they may be able to, they may screen people. So say they screen people for HPV. So that somebody does a self-swab, but then sometimes the lab doesn't actually have kits, so it's also about resource. You can't do screening if the resource isn't there, the infrastructure isn't there. People are told that the examination is painful, and that's the mentality, don't go looking for any trouble. That's what that says. So misconceptions around what screening is. And also, this in the middle picture there, Sister Helen is this incredible nurse who does women's healthcare at one of the hospitals I visited, and she does the VIA, the visual inspection herself. And she said when she offers, so they have this incredible, it's very community-based, which is incredible and very powerful, but all the women come and sit in the middle of an area where all the clinics are around, and they sit there all day waiting for an appointment. So there's 60 appointments. So there's one gynecologist, and there's 60 appointments every day, which made me feel really ashamed of how many patients I see in clinic. And so there's 60 patients, and they all sit there, and then they have education in the morning. So they'll say, oh, you should get screened, we can do this for you, we can do that for you. And she said that of those 60 patients, only about 5% of them would actually take her up on the offer of a visual inspection for cervical screening. So there really is something about having a speculum that's really not something people want to do. So it was very acceptable, self-sampling, and things like accuracy of sampling method was talked about, so they wanted it to be accurate. It could empower women, would much prefer self-sampling, especially urine, not wanting to put anything inside, especially in certain cultures. Privacy, I'd be happy to take my own sample, as I can do this by myself without exposing myself, and cost is also important, so i.e., it needs to be free so that it's accessible to us. So the future is urine. Essentially, Lois in Nairobi will be doing the analysis and results, and we'll be helping her with that, which is really exciting. We'll be looking, hopefully, to do a diagnostic test accuracy study of urine self-sampling, similar to what I did in Manchester within a Kenyan setting, so that'll be very interesting. But really, the other thing that really was very important in that setting is that vaccination rates are only about 20%, so there's a lot of work to be done around misinformation around vaccination, because they are available, but unfortunately there's a lot of misinformation. So HPV vaccination needs to be driven and improved. Screening availability needs to be there and needs to be free, but also we need treatment modalities, because there's no point in screening anybody unless there's actually a way of being able to treat these individuals. And we had fun as well and saw some big animals. Hippos are really dangerous. This was one of the scariest moments of my life, being near them. And the coffee was delicious. We met some wonderful people who are doing amazing things, very passionate about women's health. And thank you to everybody, and for the generous money as well. Oh, yeah. So this is not my urine, just... I would be very worried. This is lemon curd. This is a lemon drizzle cake made with cardamom. It was very delicious, but it didn't win the prize for best gynecological cake, sadly.
Well done. Thank you so much, Jem, for a fascinating talk and for leading us quite nicely into tea.
Yeah.
Any burning questions? Anyone want to? Yeah, I thought you might.
Thanks, Jen. Very entertaining and informative talk. I guess my question is, you've highlighted obviously the barriers to cervical screening in sub-Saharan Africa and other places. And this is a great example of how you could potentially bring women into the process. But I guess the next step is, if they are HPV positive, you are going to need to use that speculum. So do you have any thoughts on how you might then persuade the women that now they really do need to agree to it, and what you could do in that community to try and make it more feasible for them to take part in the next step?
Yeah, I mean, we did ask around, if you're positive for this virus, would you then go to the doctor? And there was a lot more. I think personal risk makes a massive difference. It certainly does as well in the UK populations that I've spoken to. But having a personal risk makes people, it gives them the impetus to think about their health and actually go and have it done. So I think it's just getting over that first step, because I think when you think there's nothing wrong, you don't particularly want to go and have that sort of examination. But I think when you're worried that there might be something wrong, there's a mentality shift. So I think it would be fine. I think people would engage. The problem is then the costs of treatment. So that's going to be a massive barrier as well, because why screen if you can't treat?
Professor Rodak.
I think you're a very worthy winner of this award, so congratulations.
Oh, thank you.
Listening to you, I thought, if it's in the urine, could the virus be in saliva?
I think that it is being looked at for head and neck HPV, for cancers.
So it has to be in close proximity to where the cancer is.
Yeah,
But
yeah.
viruses tend to spread around the body.
No, I wouldn't say so, no. But, I mean, you can certainly detect it in the blood, but that wouldn't tell you where, everybody's going to have HPV probably. It just needs to be localized to where the disease could be. So
I think in the interests of time, we should probably move on to tea. I think the programme, 15 minutes.
Well, I think we're going to get the audit, the next team, to come up and get their presentations ready. So a quick 5-minute break if anybody needs to go out to pass urine. We're going to restart if people could come back in again. Thank you. So this is the last part of the meeting, and this is where we're going to be hearing about clinical audits, quality improvement projects. And I'm delighted that the two audit leads, Jo Modder and Divya Chandrasekaran, are going to be leading on this. And they've been key members of the organisational committee. So over to you, Jo and Divya.
Thank you. Thank you. Thank you. I'm just going to wait for people to settle for the next 10 seconds. Thank you so much. So we have a very short time, but I think it's going to be a good time. And this is the audit quality improvement section. So as Ian Jacobs said earlier today, the whole point of the Institute is to be collaborative. So it's not just one, academic or just clinical. It's all the diverse specialties coming together, and that's what its strength is, I think. So this section is clinical, and we're going to just present two of the amazing audit and quality improvement projects that happen in the division over the year, and you'll have seen some on the posters. Just to report back to Prof. Rodek, the audit is no longer in Shaney's Muse with a hot lunch. It has now moved to online on Teams, and I can only say I'm very sorry. I know we failed. We will try and make it better in the future. Yes. So with no further ado, I'm just going to present I'm going to ask Claire to come up. So Claire Bovink is a complex pregnancy specialist midwife. And she's presenting a quality improvement work on the placenta accreta service. For those who don't know what this is, it's a complex surgical service which is looking at women who have adherent placentas in pregnancy, and this really increases the risk of very heavy bleeding. It's a very important service. It's not just about the surgery. It's about just supporting those women in many different ways. So, please.
Thank you, Jo. Hi, my name's Claire Bovink. As Jo said, I am the complex pregnancy specialist midwife, and I'm the lead midwife for the placenta accreta service at UCLH. The service was set up with a midwife first in post in October 2023, and the service has been up and running for the whole of 2024 now. So we wanted to go back and look at the service and the care that we've been able to provide to women. Our latest statistic from ARCOG is that placenta accreta is still very rare, occurs in only 1 to 300 to 2,000 pregnancies. I'll be looking at 12 women that delivered under the service this year. So when a pregnancy is diagnosed with placenta accreta, immediately there's a massive shift for that woman in the outcome of the rest of her pregnancy. And you can see a bit of a snapshot there of the range of professionals that they have to encounter then for the rest of their pregnancy. And what the service set out to do is to provide a named midwife in post to centralise and streamline the service and guide that woman through the service. It also was started to give a more robust pathway. So part of the work that's been developed as part of the placenta accreta service, we do have, as I said, a midwife continuity of care now. We've developed an MDT for the service, a formalised care plan that's documented in the patient records, a formalised patient information leaflet. We have really tailored psychological support with a named clinical psychologist that has contact with all these families. The postnatal follow-up that's available to these women has been massively improved, and we have sought their feedback throughout the year. So the referrals that we've received this year have mainly been from North Central London ICB hospitals, with just an outlier there that we received from Lister. The referrals are sent to the fetal medicine unit, and placenta accreta is detected at all stages throughout pregnancy. You can see in the top right there, mostly occurs between 25 to 35 weeks. So sometimes we have ample time to plan, and sometimes not so much at all. Referrals, and this is testament to our amazing fetal medicine unit, that the interval between when a referral was received at UCLH and when the patient had their first scan in the fetal medicine unit was never longer than 1 week. And as you can see there, most actually received their scan the very next day. So that's, really fantastic. I just wanted to point out as well that while I'm presenting today the outcomes of 12 ladies, there actually have been 17 patients come under the service in 2024, and those other 5 have either delivered this week or will be delivering January, February. So they have been caseloaded under the service. A snapshot of the ladies. You can see ethnicity there, maternal age, mostly in the 35 to 39 group, which is fairly in line with the general UCLH demographics anyway. We had 11 singleton pregnancies and 1 DCDA. Our average age was 34. Our average BMI was 32. Most cases had 2 previous cesarean sections, which was a change from last year. We noticed that most of the placenta accreta cases in 2023 had actually only had 1 previous C-section, and that's a common misconception, is that placenta accreta is more likely the more previous C-sections that have occurred. So just to dispel that myth that the woman who has had 1 or 2 previous cesarean sections should not be excluded from placenta accreta consideration. We did also have 1 primate lady. That was the case because she had severe endometriosis and lots of pelvic adhesions, which caused that to occur. So just to point out that we take a wide variety of patients that come under the service, and we certainly don't exclude ladies such as that under the service. So the outcomes. We're really proud to say that we've been able to get most of these women and these pregnancies all the way to late preterm. I just want to point out that 1 outlier on the very left at the top there was due to an IUD that was delivered at 23 weeks, but you can see then the rest and the majority delivering actually at 36 weeks, which is fantastic. Average estimated blood loss, as you can see there, ranged from 1 to over 10 litres with an average of 5 litres. Really, really significant compared to any other cesarean section birth. Worth pointing out in the bottom left there, you can see, hopefully that's big enough, the rates of elective C-sections in 2024, we have massively increased to 11 out of 12. In 2023, there were 11 women versus 12 women this year under the service, so comparable numbers. So through the development of a dedicated service for these ladies with really good planning and oversight, we've been able to reduce the number of emergency C-sections. And some points worth noting, 5 out of 12 ladies required hysterectomy, 5 out of 12 sustained bladder injury requiring repair, and 7 out of 12 had ureteric stenting prior to C-section. And that is not due to more occurrence of poor bladder outcomes, but actually now we've noted throughout our evaluation of the service throughout the year that actually it's best if we do that ureteric stenting as a standard now for every single case. So that's why those numbers of ureteric stenting is quite high. In the postnatal period, you can see there we do recover most of our ladies in ITU. The length of stay varied between 1 to 10 days. We don't feel that is necessarily a reflection, again, of poor outcomes, but actually that because we have the service dedicated to these ladies, our communication with ITU has been early, it's been of higher quality and really thorough, and so we were able to get those patients admitted to ITU. Postnatal follow-up became much more consistent. Again, I've compared in 2023 with 2024. The uptake of the birth reflections that our psychologist is able to offer these ladies has massively improved. The general psychological service throughout pregnancy uptake has improved. Urology postnatal follow-up, obstetric postnatal follow-up from the surgeon that performed the surgery, and 11 out of 12 of the ladies were caseloaded by myself. So I just, really want to highlight that the psychological input has been massive and really transformative for all these families. They're often, when accreta is diagnosed, they're they've got so much to cope with emotionally, including the loss, with the potential for hysterectomy, the loss of the family that they thought they might have. And just with regards to the ITU beds, thinking about the expansion of the close observation bay that's coming up in our labour ward, I think the clear need for ITU beds for these demographic of patients could definitely be incorporated, and these often are patients that we think could be excellent candidates for a HDU if that's developed in the future. And of course, that would lead to massively better psychological impact from not being separated from the babies. So what have we looked at throughout the year? We've reviewed each and every case. We have reduced the case-to-case variation that was occurring before the service was implemented, so much more standardised care pathway for these ladies now. We've hopefully improved our referral pathways from other centres in NCL to us at UCLH, and we're continuing to reach out to those trusts and hopefully improve that. We've continued to seek patient feedback, and throughout the whole year have continued to evaluate the service. Where we want to go from here, promoting the service more. As we can see, the numbers have definitely increased in 2024, and so I think that's a testament to the outreach that we've already had with other local trusts. We want to start a urology and maternity working group. We have noticed over the last few cases that the urology input required for these ladies is quite intensive, and so we want to improve those working relationships to really strengthen that pathway with the urology team. Often the ladies are going home with catheters in that are needed for weeks, and that's not something we usually see on the postnatal ward. We want to implement early neonatal input. Families have found that even though their babies are late preterm and generally well, when they have had that chance to speak to a neonatal professional, potentially have a tour of the neonatal unit, it really allays a lot of those fears and anxieties from their baby having to be admitted. And we want to audit postnatal length of admission. Often ladies are home within 1 week, which is fantastic. Recently we've had one lady that has been admitted postnatally for a month, so we need to look at why those things happen and what we can do to streamline that and get the women home. Which is all, of course, with the view of improving outcomes and experiences for our patients. As I said, we seek feedback from all of our patients, so that's just a little snapshot. We're really proud to say that the feedback has been overwhelmingly good. So we're hoping to, continue to improve and continue to support women to get the best outcomes they possibly can. For referrals, for any suspected placenta accreta, please do email our FMU. Our obstetric leads are Mr. O'Brien, Mr. Subert, and Mr. Atalakos, and of course myself as the midwife. My email is there. Thank you so much.
Thank you so much. I think we have time, I'm hoping, for a 1 or 2 questions. So, Garda.
Sorry, thank you very much. Very interesting work. I wanted to ask a couple of questions, if possible. I don't know if you mentioned what was the outcome of the delivery. I mean, in terms of, did all these women need a hysterectomy, or did some of them have...
So actually, 5 out of 12 of them required a hysterectomy. So, just short of half. Yeah, so it's definitely something that we realistically try and prepare each and every woman for.
And the rest, did they need like long stay in hospital to deliver the placenta or to observe the placenta, or was it removed during delivery?
No, so in most cases, the placenta was able to be removed. And often when there has been adherence, most of the placenta is removed and some pieces just left remaining, which have then just been passed by the woman as time passes, and we don't keep them in hospital for that. We are very lucky that we haven't had any cases of like severe ongoing infection or sepsis from that, so that's proven to work quite well, just leaving any really adherent bits of the placenta intact.
Okay, and I think the other question is, when was placenta accreta diagnosed? Do you have any data about the stage of the pregnancy? Was it an early?
Very varied. Which makes life tricky sometimes. That case that's diagnosed at 20 weeks or suspected at 20 weeks is great, because the woman can come to us, has lots of time for not only for us to plan, but for herself to process what's happening. But you can see there as well in the top right, a lot of the cases are between 31 and 35 weeks. So they're very quick, very urgent referrals, and lots of rallying to get all the professionals in the right place at the right time for this woman. And of course, before the service was implemented, that still happened. But now that we have a midwife in post, that happens a lot more smoothly because we now have that one sort of central point of contact for the patient.
Thank you. Looking to see if there's one more question. In that case, I'm going to take that question. I know a lot of women come from, well, I'm guessing they do come from out of area because it's a tertiary service. And I was just wondering, how do you support them, you know, sort of the follow-up when they go back to their local sort of place? I just wonder about that, how difficult it is.
Yeah. So we certainly do, as per the standard pathway, refer back to the local trust for their community midwifery visits. Sometimes urology input is required, and so we do get the ladies to come physically back to us at UCLH when they need cystogram and all that sort of thing. We also are quite open to offering our postnatal follow-up from the obstetric and the midwifery perspective over the phone. Certainly our clinical psychologist, she can definitely speak to the ladies over the phone. Yeah.
Thank you very much. Thank you. So our eyes have been opened to a new service. Thank you.
Thanks, Joe. Hi there, I'm Divya Chandrasekhan, one of the gynae oncologists at UCLH and the gynae audit lead here. Katrina Sherlock's going to bring up our next talk. So Katrina is currently in ST5 and is undertaking an outer program and registered for a PhD here at UCL, is that right? And working with the Repro Med unit. This is very interesting for us gynecologists who do on-calls here at UCH. It's a problem that we see more frequently. It feels like every year is slightly more frequent. So looking at it's a very nice title, Hidden Hazards of Fertility Interventions. So off you go. Thank you, Katrina.
Thank you so much, and thank you for the opportunity to present our work to the Institute today. I'm very grateful. Our project is regarding the hidden hazards, potentially, of IVF and fertility treatment. So I'm Katrina, I'm a registrar and a clinical fellow in the reproductive medicine unit, and I work alongside our project team, Ms. Balachandran, Mr. Lavery and Ms. Kanjani. And we're all gynecologists who have experience within the unit of managing women who have been admitted with complications of fertility treatment to UCLH. And we noticed that there were some women being admitted with quite severe complications with prolonged hospital stays, and that really triggered us to try and investigate, trying to get a bigger picture of what's happening over the last few years in admissions to our service. The fertility sector, I'm sure many of you know, is a very regulated sector, and the Human Fertility and Embryology Authority, the HFEA, published reports which really helpfully provide some insight into the state of the sector on a national level. So we know that, for example, in 2022, more than 52,000 patients underwent IVF, that there have been nearly 80,000 cycles in the year of 2022, and there's over a 10% rise since pre-pandemic levels in 2019. So more IVF and fertility treatment is happening. And actually, the proportion of NHS-funded cycles has fallen, so more is happening in the private sector. The other really interesting statistic from the latest report is that the number of egg freezing or elective or social egg freezing cycles are on the rise. So at the moment this sits at around 5%, but that's an 81% increase in 2022 on 2019. And you know, we see that in society, that there's a cultural shift that women are aiming for later parenthood. There is encouragement from some employers, for example, such as Google, Microsoft. Some of the big employers pay for women to have egg freezing. And as we saw in the debate this morning, that women are encouraged to have a choice. So there is more egg freezing happening. Not all fertility treatments will go without consequence or adverse incidents. So the HFEA also have a code of practice, which is a statutory requirement to try and report these incidents back to the HFEA to keep a track of what's happening, to ensure that their causes are identified and that this can be fed back to fertility providers. It's important to say that actually more than 99% of fertility treatment cycles will go without any incident and are straightforward. But centres do have a duty to report incidents to the HFEA if they're the primary treating centre within 12 hours of them being notified of the complication. and what the HFEA ask on the clinical front, because they also take embryology and consent issues, but on the clinical side of incidents, they want to know about severe ovarian hyperstimulation syndrome, which is an adverse effect of fertility treatments, and also any untoward occurrence that may result in prolonged hospitalisation or illness. From the statistics that they then publish in the reports, the only thing they publish on the national level is the severe hyperstimulation cases. And in the most recent report, this affected 0.1% of cycles, so 1 in 1,000 women who undertake fertility treatment. And why are we in a really privileged and good position to have an insight and be able to give you a picture of clinical incidents that are happening beyond what the HFEA report? Well, there are 107 clinics that are licensed by the HFEA, but a third of them are based in London. And at UCLH, as an acute NHS centre, we're surrounded within a 5-mile radius by 21 of these private providers offering treatment. And what we also know about private providers is that they are not in a position to provide acute treatment or admission to hospital for, consequences and sequelae of treatment. What are the potential complications that women might experience? So we're in the process of delving through the literature and doing a big review at the moment of literature from the year 2000 onwards. We know that transvaginal oocyte retrieval, as I've said, is generally safe. It's been used and described since 1985. And the vast majority of women, the main complication reported is vaginal bleeding, so up to about 18% of women. Anything more serious is uncommon. Severe OHSS, 0.1%, intra-abdominal bleeds, less than 1%. Other possibilities would be pelvic infection, adnexal torsion. VTE, there's been a new guidance by the British Fertility Society published recently by Ms. Balachandran, actually one of the members of our team, where they don't know the exact incidence of VTE following fertility treatment, but it's thought it's up to a 9-fold increase relative to non-IVF pregnancies. And then there are case reports in the literature and series of much rarer complications. So arterial thromboembolism, cyst rupture, which is associated with endometrioma and dermoids, pelvic organ injury, which can have longer-term consequences or may be picked up in pregnancy, and rarely there would be incidences of maternal death. And this was the biggest series completed in the Netherlands, which doesn't necessarily reflect up-to-date data and IVF as it's done now because multiple pregnancy and OHSS rates have reduced, but found that actually the IVF procedure itself doesn't increase the risk of death over the general population rate, but IVF and then ongoing pregnancy did have a higher rate of maternal death than non-IVF pregnancies. On the right, the table there is just to give you an overview. Based on the literature that we've found, actually, there are single-centre retrospective studies reporting on complication incidents from around the world and also national registry data that has been published, but there isn't, to our knowledge, a UK registry of data that's been published to date, despite it being reported in. So what do we aim to do from this project? We wanted to clarify our experience as a tertiary centre in the midst of private providers of the nature of admissions and their severity. And how do we do this? So we reviewed all acute gynecology acute admissions through the gynecology admission lists and through the procedure where the general gynecology team report back to the fertility team to notify of admissions. And this was done from July 2021 onwards. And what did we find? Well, 64 women were admitted during that time frame, with an age range of median of 35 years. In keeping with where most women are treated, the majority had had their treatment in the private centre, 23% were NHS, and then 5% had had fertility treatment overseas and then presented to UCLH with a complication. The treatment performed, again for the majority, was IVF, 80%. Interesting number is that 11% of those admitted, 7 women had had elective egg freezing in the private sector, higher than the rate of elective egg freezing performed. And then there were other treatments performed. So for 6 women, they were individual cases of medical fertility preservation, donor oocyte cycle, investigations for subfertility, like a hysteroscopy or a hycosi. So these were individual cases. So this is the list of complications and the number that we found. A couple of things that are interesting from this is that actually admission with pelvic hemorrhage was more common than admission with severe OHSS, which is what's published currently at a national level by the HFEA. If you take away the ovarian hyperstimulation cases or pregnancy complications, the rest of the complications make up 42% of the admissions. So all of this information should be fed back to the HFEA, but it's not currently published, so we don't know what this is at a higher level, and it's not presented out there to the fertility sector. How were the women who were admitted managed? Well, 50 of the 64 had conservative ward-based treatments, so we class this as women who were on the ward, had fluids, analgesia, observation, and then managed to go home, antibiotics or blood transfusion if needed. From a breakdown of those, all 14 women who'd had their primary fertility treatments within our unit, the reproductive medicine unit, had been managed conservatively on the ward. So for the other 14 women who needed escalation of their care, they'd all had their initial treatment in a private provider. There's some examples there, and I've given a little detail of the type of treatments they had. One thing that's interesting from this is that 4 out of the 7 women who'd had elective egg freezing needed escalation of care. To pull out a couple of cases, the first is a woman who was 39, elective egg freezing. She was then admitted to ITU with severe pelvic infection that required draining. She had 2 admissions and a very prolonged hospital stay. And now, as a consequence of this, she has tubal factor subfertility, which she will carry on with her, and long-term psychological implications too. Another example further down the list is a lady who recently was admitted, I'm sure some of the gynecologists will know, who was admitted with an acute pelvic hemorrhage following elective egg freezing, and was taken to theatre from A&E Rhesus with 5.5 litres of blood in her abdomen, requiring a laparotomy, 8 units of packed red cells, multiple other blood products. We actually saw her for another follow-up yesterday in the department. She's well, but this was based on an elective egg freezing cycle that she had. So these are just some examples for you. Length of hospital stay varied across providers. You can see that the medians are actually 2 to 4 days, but some women did have much longer hospital stays, up to 26. So in summary for our audit, what we found is that actually IVF is generally very safe, that IVF and elective egg freezing cycles are on the rise, and this is all performed mainly in the private sector, and NHS cycles are falling. That NHS services by nature carry the responsibility of admitting patients acutely and managing any complications that arise. But the HFEA adverse incident reporting needs to be fed back to the primary treating centre. And there's potentially a gap there of human error and issues of patients having to manage a complication and needing to feed back to their centre, or how does this process happen? And what this review on a patient level revealed to us was there are prolonged admissions, significant interventions and ITU admissions, and then things that aren't reported on top of that are long-term morbidity, psychological and subfertility impacts for these women. So where are we going from here? On a local level, we've already presented to the gynecology audit meeting to try and raise awareness and our pathway within the team. We are planning to present to the Obs and Gynae junior doctors in the new year on the complications of fertility, and we've started a prospective database within our department to keep a track of complications and admissions. Really exciting, we've got a couple of things happening on a national level. So we're presenting to the British Fertility Society in January and currently reviewing the data ready to publish. But we've also started a collaboration with the HFEA, the regulator, to understand the national picture of these adverse incidents and whether or not they're underreported. At the moment, we can't say that, but the HFEA have heard our data and they're really keen to work with us to try and develop a national picture and for us to be able to use their data to do that. Obviously, building on from that then, there are important things that need to be considered. The quality of the data that's being reported back, because a lot of it is free text from the provider at the moment, the fertility provider reporting the incident. But overall, the most important thing is that this has implications for the women that we treat, for the way that they have been consented and their information and knowledge of the rare but potentially serious outcomes of the treatments that they undertake. So hopefully we'll be able to have a good picture to offer important updates on consent for the patients that we look after. Thank you so much for your attention. I'd like to thank our project team, Mr. Lavery in particular, who's opened doors for us with the HFEA, and welcome any questions.
Thanks, Katrina. Oh, Adam's hand's gone up straight away.
It's the second time I've heard that, and congratulations again, because it's a great piece of work and incredibly important and very, very topical. Just remind me, what date did you finish the audit on?
So we've continued up until the end of October, start of November now. This
okay,
month.
so I think you've probably got one of my cases in there, but on Monday I did another. So in the last 2 to 3 months, I've done 2 emergency laparoscopies. The first one about 1.5 litres. It was 3.5 litres on Monday. Elective egg freezing for social reasons. She's beating herself up over it enormously. She's deeply traumatized by it. She's thinking, why on earth did I go through this? And I'm thinking, well, you've been in a hospital bed now for nearly a week. You've probably cost the NHS a 6-figure sum, I suspect. I may be wrong, but I wouldn't be surprised. So this is, a national issue, mainly in London, admittedly, judging by your map. But let's face it, the private IVF world is making a lot of money out of these kinds of procedures. If Google is paying for its employees to have elective freezing, just maybe they should be paying a little bit of an NHS tax for paying for us to be doing this sort of thing. The NHS has not got the resources to deal with what are actually socially indicated surgeries and their complications. There is no spare capacity in this system. There hasn't been for years. There never will be. So we need more money from whatever source, be it Google or the IVF clinics themselves, and getting this data together and getting it published. It will get into national media, and then hopefully your work will lead to genuine change. So huge congratulations.
Thank you.
I've got a microphone here. Is it okay to go ahead and ask a question?
Sorry, yeah.
Hi there, I'm Zainab Gurtan. I'm a lecturer at the Institute for Women's Health. And I'm also on the HFEA authority. I'm an authority member. So I really, really welcome this research. We have been having lots of discussions in the HFEA about whether adverse incidents are underreported. And part of the reason for that is because some private clinics apply a time limit on how soon after an incident they will report. And of course, patients don't always go directly back to their clinic to report what's happened to them. So I just wanted to find out a little bit about whether in your sample of 64, do you have a sense of how many of those were actually reported to the HFEA, and how many of the patients actually went back and got in touch with their clinics?
I think that we definitely wouldn't have an accurate report of that. So having been through all of the patients' individual notes, obviously 14 of the 64 came from our centre.
Yeah.
Of the other 50, many of them had been, there were a reasonable group of them that were referred in from their private provider, but there were others where I don't have the data based on their clinical notes and looking retrospectively as to whether or not they did go back.
Hello. I actually interviewed a woman about 2 years ago who did elective egg freezing and ended up in hospital. She didn't go back to her clinic until about maybe 2 months after. She was quite traumatized. When she went back to her private clinic and told them that this had happened, and she suggested that they report it as an adverse incident, the clinic told her that if she really wanted them to do that, maybe she should think about moving her eggs elsewhere.
I mean, that's really difficult to hear, isn't it?
Yeah.
I think when we met with the HFEA, they're really keen to be engaged with this as well with us, and there shouldn't be a time limit on when patients can go back. But in a way, when the patient's managing the complication, it's difficult to put the onus on the patient as well to be reporting. So it's something that we are working with them to try and move forward with.
Well, thank you. Very nice presentation. With the all underreported and complication that you have been told, can you infer that it can be recommended that in the UK, the fertility clinics should be physically attached to the hospital, so the reporting and the management can be comprehensive and not to be delayed, or for the Dr. Zainab said, like underreported like that? Thank you.
I understand what you're saying. I think there are so many well-established satellite and freestanding units that it would be difficult to put into place. But I think if we improve the process from the patient education pre-treatment, the expectation of the clinic, and also the expectation then at the point of reporting, then hopefully we could overcome some of those measures.
I think you might have presented this last time. If you take into account the number of cycles that go on in those 5-mile radius to the proportion of people who presented, can you hazard a guesstimation of like the rate of serious complications?
So we haven't done it at a regional level. We've done it internally, and we have a low rate of complications relative to what's there in the literature. So that's what we found internally, but we haven't done it at a regional level.
Okay, great. Thanks, everyone. And, more questions, Melanie, yes.
Is it okay to quickly respond to Professor Rosenthal's comment, with which I do agree, and it was the same 10 years ago when there was a big campaign to reduce multiple pregnancies from IVF, and so Britain moved to a single embryo transfer policy. But we got lots and lots of multiple pregnancies of higher order with all those complications from overseas treatment. But, you know, we've just been talking about placenta accreta service as well, and that is fueled by women having elective procedures. We talked about choice earlier. I mean, can we deny choice to women who want to freeze their eggs, or deny choice to women who want an elective caesarean? It's the way the world is going. The NHS keeps picking up the tab.
Yeah, I think I tend to agree with you. I think Adam and I, we are so in tune to treating women with a problem that it's often not their fault, and not doing anything about it leads to death in terms of cancer. And I think we're probably less sensitive, or I think we're just less aware of choice. And, you know, majority of what we treat is to do with lifestyle and about choice. And it seems unfair to suggest that we should tax people because they provide something that patients want and it's their choice. But I'm certainly guilty of being less sympathetic to consequences of people's choices, whereas most of my patients, they haven't had a choice in what they've developed. It's kind of something out of their control. But anyway, thank you. Lots of debate.
Thank you so much.
Very much.
Well, we're going to move swiftly on now to session 10 in the programme, which is focusing on some of the global reach of the Institute. And it's my pleasure to introduce Professor Jenny Hall as Professor of Sexual and Reproductive Health, who's going to talk about global connections the next 20 years.
Thank you, Howard, and hello, everyone. So I think this morning we spent about an hour talking about the last 20 years, and I've got 10 minutes to talk about the last 20 years and the next 20 years. So please bear with me if I can't do justice to all the things that have happened or all the things that are planned. And I'm going to talk about a selection of things, so it's not everyone's, and I'm also, most of this is not my work, so again, apologies for the lack of detail, but there's contact details for everyone on the slide, so if you want to find out any more about any of those things, you can get in touch with those people. But in this session, what I'm hopefully going to do is give you a bit of a flavour of how the Institute is working towards that mission of better lives for women and babies around the world. And here I'm really focusing on projects that have either a global focus or on low and middle income countries. So starting with women's cancer and led by Alex, they are working with industry and with colleagues in Tanzania on a new study looking at the acceptability of a diagnostic tampon for human papilloma virus screening in Tanzania. I think maybe the earlier speaker should link up on this. But they have a bit of money at the moment where they're looking at the acceptability. They've got a visit planned next year, and they're looking at reviewing the literature at the moment with a plan to submit for more funding to do a larger piece of work on that. We've already heard about some of the links with Uganda that started right at the beginning of the Institute, and the Maternal and Fetal Medicine Department are continuing those links with the SCALE project, which aims to support training in maternal fetal medicine in Uganda, and this is in collaboration with Makerere. So over the last few years, they've conducted a number of grand rounds had case-based training with Q&As, and you can see all the people here who've presented the different grand rounds over the last couple of years. And going forward, they are expanding the access to this by using Zoom to enable more participants to attend, and they're also uploading the grand rounds to YouTube so that everyone can see those. In neonatology, as well as the work Nikki mentioned earlier about saving babies' brains in Uganda, Shuba's leading this work with AIMS, which is a premier institute in India, where they are developing a wearable, light-based sensor for real-time cot-side monitoring of placental function. They are working on Prospect 1 at the moment, still recruiting, and are planning for Prospect 2, with more sites including in the States. And then finally, in reproductive health, Eric is working on the global issue of climate change and the links between environmental pollution and women's health, which we heard some more about this morning. And then Judith, myself, and others have been working with the World Health Organization on preconception health, and Judith is co-leading this work on the international core indicators for preconception health and equity, and you can see from the map that this is a really global piece of work, which is bringing academics, clinicians, and the members of the public together to achieve consensus around a set of core indicators for monitoring and surveillance of preconception health. So that's just a snapshot from each of the different departments of some of the global health work that is going on, has been going on and is going on now. And my last two slides are to talk about things that you might be able to get involved with. So if you have been inspired by Bo's talk about the importance of global health leadership around women's health and newborn and child health, then here are two opportunities for you. So the first one is REACH. So REACH is an initiative that's based in Toronto and led by students to investigate important topics that are aligned to the Sustainable Development Goals. The whole centering of the purpose is to focus on reaching those in difficult to reach areas, so those in extreme poverty or those in physically remote areas. And the Institute for Women's Health supported the UCL adoption of REACH and has run 2 cycles of this already, led by Sarah Hillman. And I think it's a really important initiative for the Institute to continue being involved in, because there are lots of topics that are really important for women's health that are covered by REACH. It is a really competitive, selective process for students to get onto one of these projects. So you do get really excellent students, and they often go on to publish their work. So the reference at the bottom here from Francesca, she was one of the students last year. She won the Best Poster Prize here at the conference last year, and she's now published that work, which is looking at the role of stigma on the pregnancy experiences of women with disabilities in Kathmandu. So if anyone is interested in supporting this work going forward with REACH, then please get in touch with Sarah. And then lastly, in 2026, UCL will co-host the next GLOW conference. So for anyone who doesn't know GLOW, it's a society called the Global Women's Research Society. It's for anyone who is interested in or currently working in global maternal, newborn, child and reproductive health. I've been on the steering committee for GLOW for about the last 6 years. We have a conference every other year. This year's conference was in Edinburgh. It was absolutely fantastic, a 2-day conference on rising to the challenges in maternal health. So we were talking about climate change, we were talking about conflict, really, really interesting things. So myself and Professor Joy Lawn, who's a professor at the London School of Hygiene and Tropical Medicine, agreed to co-host the next one, and that will be collaboratively between Institute for Women's Health, Institute for Women's Health, Institute for Global Health, and Institute for Child Health. We are just about to start planning it, so if anyone is interested in joining the local organising committee, then please email me, and we'll get going on that in the new year. So I hope that's given you an insight into some of the ways that the Institute is working to improve the lives of women and babies around the world, and also some ways that you can get involved and make changes yourself. Thanks.
Well, Thank you very much, Jenny, for a brilliant overview of everything that's going on. In the interest of time, I think people know how to get in touch with you if they have any questions and want to get involved. But thanks for sticking to time. That's really helpful, because we're now going to move on to session 11. I think Sarah Hillman. There we are. Sarah's chairing the next session.
Thank you, Howard. Moving on very promptly, we've got Vicky Boydell, who's going to give us, I think, what should be a really interesting talk. You know, we've heard some experiences from one side, but it would be really interesting just to explore a bit about health workers and others' experiences of this situation. So she's going to talk to us about violence and hostility against sexual and reproductive health rights and justice workers.
Great. Thank you so much, Sarah, and very happy to present this work to you today. This is work that I've been doing in collaboration with several consortium partners, including FIGO, the International Confederation of Midwives, International Planned Parenthood Federation, IPAS, MSI Reproductive Choices, and ODAS, which is a consortium of sexual and reproductive health providers in West Africa. And it's interesting to come after Jenny's presentation, because sadly this is a trend in global health, in women's health more generally, that I think we really need to talk about and address. So basically all these consortium partners came together about 3 years ago, because we'd all been anecdotally hearing about the same kind of issues that were coming up through their professional associations or through service provision. And this was anecdotal accounts of the violence and hostility that was happening against frontline providers in a range of different sexual and reproductive health areas. And so we decided to kind of more systematically look at this topic and do some action research about it. So just to provide a little bit of background, looking at some of the systematic reviews around hostility and violence to health workers more generally. So 60% of health workers experience some kind of violence in the workplace. This tends to be perpetuated by patients and or their families in the workplace due to frustration, fears, stress, or, in generally emotionally charged situations. We also know that not all health services are the same, and some health services have higher rates of violence and hostility. A&E, mental health, substance abuse clinics, and ambulatory care more generally. And we know women experience more violence in the workplace than their male counterparts. But we know very little about the violence and harassment for more highly politicized healthcare services. So our consortium started to do some action research on, what violence and harassment looks like in these highly politicized healthcare services, particularly health, sexual and reproductive health as women's health more broadly. Here we are focusing on action research, so we're really doing research to find solutions to safeguard and protect those working on the front lines and support them to protect their rights and to do their work in a general way. So we put together a call to action that was published in BMJ Global Health in 2022, and really setting out our agenda also to be transparent about the work we're doing, but to be accountable. So as a group, this is what we intend to do, and so to make sure people hold us accountable for what we're intending. And first was to strengthen and support protection for those providing and advocating for sexual and reproductive health services, and then to enhance kind of the response to reprisals, so those attacks against frontline workers, and make sure their working conditions are safer for them. And so we did this action research in 2 parts. We did a scoping review, and then once we started the scoping review, we realized there was very little material, so then we went and did in-depth kind of exploratory research with those working on the front lines. So the scoping review, which we published last year in 2023, included peer-reviewed literature, it included gray literature, it included news reports. We looked at survey instruments as well, and we did expert interviews. And so using those more standard kind of, evidence synthesis instruments of looking at gray literature and the peer-reviewed literature, we found that there was very little attention focused on the hostility and harassment of those working on the front lines of sexual and reproductive health care. And if we just relied on that information, it would tell us that these instances are very rare and they're not happening on a regular basis. So hence, when we start to look at kind of the news reports out there, we started looking at the survey data, and we started looking, speaking to experts working in the field, we found that, people were experiencing harassment. It was being documented in the news reports. There are several survey instruments out there collecting information, particularly in relation to abortion services, and that when we spoke to people working on the front lines of sexual and reproductive health, they have a whole set of mitigation strategies in place to protect those working on the front lines, but this is just not captured in kind of the evidence base out there. So we decided to extend our research. Well, the kind of main conclusions from the scoping review is that on the whole, there is a systematic silence about the hostilities faced by those working on the front lines of sexual and reproductive health across a range of sources. When they do look at hostilities, they're kind of reported as one-off events, or they're treated as individualized instances. So it's not seen as a systematic or coordinated phenomena. And there's little to no kind of focus on accountability for those who are perpetuating the violence and harassment, and no redress for the victims who are experiencing or the safeguards put in place. So in general, when we look at what's out there on the evidence, we can see that this issue of harassment violence on the front lines is being depoliticized overall. So, given the lack of material we saw in the existing evidence, we decided to collect some primary data. This is very much an exploratory study. We were looking for a smoke signal in kind of collecting testimonials of those working on the front lines. We reached out to the consortium members, who then reached out to their networks, their professional associations, and their service providers to look for people to participate so we can start to better understand what's happening in and around hostility for those working on the front line. And you can see we spoke to 23 members who all consented to be interviewed. We interviewed in 4 different languages to make sure we had the kind of regional representation, so we weren't just focusing on certain countries. We spoke to a range of different frontline providers, and in that we included counselors, administrative staff, medical, clinical staff, as well as advocates doing the political work around sexual and reproductive health. Predominantly female, a few male, and a few non-binary participants as well. So we tried to get a range and diversity in the small sample that we were trying to use as our smoke signal to better understand the phenomena of hostility and violence. So what did we learn looking at this small sample? So firstly, we learned that all respondents, whether male, female, or non-binary, reported being subject to hostility and living with fear of them, or knowing of reprisals against their colleagues. So as one colleague in West Africa, a peer educator, told us that all the time, whether online, in the neighborhoods, everywhere, fathers, teachers, married men, especially those we denounce, they don't see us in a good light. We're constantly threatened, and we not direct threats, but shocking remarks, humiliating remarks, insults, and we don't feel safe in the work that we do. So it's quite telling, the experience that people are having overall. We also learned that hostility, harassment, and violence takes many forms. So there's attacks against the workplace, there's verbal abuse, there's hate speech online, there's legal threats, frequent reports of death threats, threats against people's families, people being illegally detained by the police or detained by the communities they work in. There were accounts of physical assault. We had a few accounts of rape and murder as well. So, it's quite telling what's happening for people working in the areas of sexual and reproductive health globally on a day-to-day basis. We also found that such hostilities and violence have several effects. So there's the more personal effects, so that's the more immediate response, the sense of embarrassment, shame, feeling shaken and disheartened. And many feeling insecure, unheard, afraid, vulnerable. This is not how we want our colleagues working in this area to be feeling on a day-to-day basis when they come to work. There's also effects on the workplace in terms of the physical infrastructure of the workplace being attacked. And a colleague from Nepal talked about how their health center was being attacked. They were being stoned, glass was being broken. And they were inside the building, and their receptionist staff got physically injured during one of these attacks. So this is providing, a range of sexual and reproductive health services. This is not just limited to abortion, which is what I think we tend to see overall. And then what was quite telling is that the effects of violence spread beyond the workplace, and it bled into people's personal lives. It was very much something that followed them home. People used to write letters to them, they'd be chased home on the back with bicycles in their cars, etc. So it's something that bled into their day-to-day life, which makes it quite distinct from kind of the accounts of workplace violence and healthcare more broadly. What was also very interesting and quite telling, particularly when we think about the global health context that we're all working in, is who are the perpetuators of this violence. So one thing that came across, often for those who were providing these services within a public health setting as opposed to working in a specialist setting, it was coming from colleagues. They were being, insulted, dismissed, ignored, gaslit by their colleagues that they were working with on a day-to-day basis. It was also coming from organized groups, people that, were collectively working on an anti-gender, anti-rights motivation, who were, either doing like online, blitzes on people's, accounts, or calling up their reception staff and like breathing heavily on the phone for hours and hours on end. And it was also coming from authority figures. So that was from religious leaders, it was from police, it was from court officials. It was made not only permissible, but they were actually, actively looking to, make sure that people's work was being constrained, and they were being pointed out and kind of embarrassed and or detained for the work that they were doing. So in terms of the conclusions of what we found from kind of our 23 interviews is that, violence is not confined to the workplace for those working in sexual and reproductive health across a range of different areas of sexual and reproductive health. And then it also bleeds into all aspects of their life, into their family life, where they have to, they can't attend PTA meetings for, being, called out for working on different issues, talking about sexuality, talking about abortion, etc. It affected their social lives. People were being dumped by boyfriends because their father didn't approve of the work that they were doing, and it bled into people's public lives in general, so what they could and could not participate in society overall. And the other thing that's very striking about this that is different from kind of workplace violence more generally is that the violence was organized. It was intentionally cultivated and driven by cross-national coordinated anti-gender and anti-rights movement. And this was creating a lot of support and energy around, particularly picking on this particular segment of the health workforce. And I just want to conclude by saying this is really a live issue. So since working on these two pieces of research, this has now fed into some work we've been doing with Amnesty International, who is launching a campaign on December 10th, which is the Human Rights Day. And basically this work there is specifically focusing on the work around abortion care and providing safeguarding principles for those working in abortion care more generally. And then on January 20th, when the Trump administration initiates, there is full expectations that Project 2025 will be put into place, which will further legitimize kind of attacks on sexual and reproductive health rights in general, and kind of creating an atmosphere where it's more permissible to attack those people, but also to channel funding into those coordinated groups that are working to limit people's sexual and reproductive health and rights more generally. So thank you very much.
Thank you, Vicky. That was a really fascinating but slightly sobering insight into things. Have we got any questions? I mean, I've got one just in terms of the reflection about violence in society in general and how similar it is in terms of looking at solutions. Do you kind of go to more ideas around what's working in those countries already, or is it a completely different strategy you take?
So I think there's already been quite a lot of work that individual organizations have been doing to kind of put in kind of mitigation strategies or kind of crisis response activities, but it's very much based in individual organizations as opposed to being more of a standard across different areas that people are adopting and implementing. But I think it is very particular because the attacks, violence has so many different causes and roots, and this is ideologically charged violence. So I think it makes it very particular and very much focused on kind of doing value clarification work, for example.
Yes, Judith.
Thanks very much, Vicky, for telling us what we all ought to know about as members of the Institute for Women's Health. I'm sorry to say. The question that I've been curious about for a while recently, and you've worked in this field for a couple of decades or more, right, in sexual and reproductive health and rights. So my question is, how much do you think this has got worse? Or how much has the lid just been taken off, what was always there but we weren't so much aware of?
So I think there's several things that are happening. I think that in terms of support, sponsorship, and training for groups who are purposefully attacking sexual and reproductive health, people have been doing research to track the funding that's gone into that. And so there has been, if you follow the money, you can see that there's been increased funding in supporting kind of, legitimizing and kind of equipping, the anti-rights, anti-gender movement more generally. And this is kind of what we wanted to know. This was the kind of the root of why we started doing this work, is because what we'd like to know is about the prevalence and frequency of this hostility and violence, and see if we can see trends over time, and I think... I think it's, longer, 15 years at this point, 15, 20 years that people have seen that kind of, but we don't know, and this is the thing, we just don't know, and we don't put the safeguards in place. So hence we wanted to do this work so we could start to think about how can we start to better understand and monitor and respond, so our colleagues are protected in doing their day-to-day job effectively. But, yeah.
Thank you, Vicky, that was really interesting.
So I'm going to hand over to Melissa, who's going to introduce Salsabil Kelsey. After you go.
Thank you, Anna. So I'm here on behalf of Jan Halsey, who's one of our midwifery lecturers who couldn't be here this afternoon. So I'm really delighted to introduce Salsa, who is a UCL graduate from summer 2024, currently working as a Foundation Year 1 doctor out in Wexham Park. And Salsa is someone who's been linked to the Institute for a few years now. So she did her IBSc back in the pandemic times, so 2021 was her IBSc third year. And she did some research with Dimitrios and colleagues, and then came into her fifth year clinical obs and gynae, and then came back to us again for her elective last year, and then went on to do her finals and graduated. And we were really delighted to find out that she had done pretty well in her finals. And if you do pretty well in your finals, and by that I mean if you are in the top 3 or 4 of the whole cohort for the UCL students, then you get put into the mix for something called the University of London Gold Medal. And this is a little extra challenge for those of you who do pretty well in your finals. And we were even more delighted when Salsa was awarded the University of London Gold Medal. Because we feel like we are her mothership, and we're very much hoping that she will stay involved with women's health and obs and gynae in the future. So we thought it would be really nice for her to come and share a few insights about having been a student and now moving into her postgraduate phase, to share with you all. So I'm going to invite Salsa to the floor, and thank you to the Institute for inviting her to come and speak.
Thank you for that lovely introduction. I get to skip a few slides now because you've done my job for me. So I just wanted to start by saying thank you for having me. Like Miss Whitten said, I think my connection with the Institute goes back a few years now, and I was saying this morning, it feels like I'm coming home when I was on my way here. As was very nicely summarised by Miss Whitten, I just wanted to talk about what the Viva itself actually is, because often people aren't too sure about it. So it's between the 5 London medical schools, those being King's, Queen Mary's, St George's and Imperial and UCL. Actually, when you find out that you're sitting for the Viva, you have no idea what it's going to be about until 7 days before the Viva. Each candidate is sent an email with the list of topics they'll be examined on and the specialist who will be examining them. In the 2024 exam, we were listed for Viva stations that covered emergency medicine, psychiatry, toxicology, general medicine, surgery, and obs and gynae. And the interview panel included specialists from Oxford and Cambridge, as well as ex-presidents of the Royal Society of Emergency Medicine. So daunting to say the least. As was alluded to in the title and by Miss Whitten, I went on to win the competition, which in itself was an incredible honour and something I wasn't expecting at all. But it was made even more special by the fact that it was the 4th time in a row that UCL had brought the medal home. So watch out, we're expecting another winner this year, hopefully. I always say that the Viva itself was not a knowledge competition. Some of the people I met were incredible and far more intelligent than I am. And it's not a knowledge competition at all. It's more a competition of wit, an ability to vocalize clinical reasoning, to manage a patient holistically and beyond just the specialty that you're discussing at the time. I very much credit my ability to doing that in the Viva to the mentorship and the training that I received at UCL, including the Institute, which is why I wanted to use the remaining minutes that I have to just reflect on the components of my medical education that I most valued, and that I really feel has structured who I am, not just as who I was as a medical student, I should say, but also now as a foundation doctor. So, the first one is the real emphasis that is placed on understanding. The first point on the slide might be slightly controversial, as I'm well aware that we're trying to move away from a traditional medical school structure and by condensing the preclinical years of medical school, but I actually personally think it's got an incredible amount of value. While I by no means remember the stages of the Krebs cycle or wish to ever relearn it, I do feel that those dedicated first 2 years have forced a really deep understanding of anatomy, biochemistry, molecular biology, and antibiotic pathways, which created a foundation and a memory to refer back to. I truly believe this helped with revising concepts and being able to navigate new concepts, even when they weren't all that familiar. The next point on the slide very much relates to my time spent at the Institute. The Women's Health IBSc had an excellent balance of making learning and content manageable while providing those who were interested the opportunity to push themselves and learn higher concepts. New knowledge, particularly that which relates to pathophysiology on an immune, cellular, and pathway level, can be incredibly intimidating at an undergraduate level. And often deemed less important because the overall aim of the MBBS degree is to produce a safe and clinically competent F1. I distinctly remember a lecture that was delivered by Miss Whitten, where that was focused on preeclampsia. And during that lecture, she specifically highlighted which parts of her slide and her teaching were important for exams, which parts were essential for being a safe junior doctor and being clinically competent. But she still went on to discuss the proposed pathophysiology that underlines preeclampsia. And making that distinction really allowed me to appreciate her teaching and discussion without the anxiety or feeling I needed to recall specifics. It meant that I actually allowed myself the time to understand and follow her explanation, and those moments really stuck with me. Looking back, I really do wonder whether Miss Whitten had a crystal ball, because my obs and gynae examiner asked me to outline whether I feel preeclampsia is a preventable disease and link that to the pathophysiology of preeclampsia. I am well aware that many of you give lectures to medical students. I've received many from all of you. And so I would really encourage you to keep those higher educational, higher level content in, with the caveat that this is just for knowledge, to actually allow students to explore that knowledge if they feel kind of drawn to it, like I did. The next point is the ability to switch between specialties. Now, I think medical students often struggle to formulate holistic management plans and consider broad differentials, as well as psychosocial factors. I think those who are able to are incredibly impressive, because that skill alone is often a product of experience, exposure to difficult clinical scenarios, and complex cases. It's a skill I'm very much still actively trying to refine, but I feel that experience in obs and gynae particularly helpful. I think obs and gynae professionals deliver very good presentation-focused teaching sessions. I received one myself on headaches in pregnancy, and actually the way that was structured was incredibly useful, as the lecture structured the session to encompass both pregnancy-related differentials such as preeclampsia and non-pregnancy-related differentials like migraine and tension headaches. That mixture and the overlap of specialties within one session actually better reflects our clinical thinking and how clinicians formulate differentials. And so introducing this cross-specialty teaching at an earlier age in medical training really helps develop clinical acumen, as well as how you present your thoughts and ideas, which I feel really helps. It also helps to allow students to consider differentials without hyperfixating on the specialty they feel they're being examined on or they're currently trying to learn at the moment, and encourage them to utilize knowledge that they already have. The next 2 points really do link into obs and gynae as well. At the early stage of this profession, I think being able to appreciate the psychosocial needs of patients is challenging. I was fortunate enough to encounter really supportive clinicians who took the time to not only teach on the wards on real patients, but allowed me to be a part of the clinical team. A part of being in the clinical team is being witness to challenging conversations and difficult consultations with patients, including breaking bad news. I think that's really important to allow medical students to be exposed to, because it really encompasses the fact that each patient's completely different. How they're going to respond to that news is challenging to predict, but there are often common concerns and worries. And once you have that understanding, you can begin to appreciate the concerns that your patients have and better formulate these holistic management plans that I think we often expect undergraduates to be able to supply, but without any clinical experience. So I very much think being exposed to difficult scenarios, although it has a toll, has amazing benefit and has made me a lot more confident as a junior doctor. Passionate teachers. So before the IBSc, I had very little experience with research and medical academia. I think research by nature can be very specific, and yet medicine as a whole is very broad. So I'd not felt drawn to a specific topic, and in turn didn't feel I fit into the research world. This all changed when we were required to select our dissertation topic and a supervisor during the IBSc, and I was fortunate enough to meet Professor Sayasakos. Given who I did my dissertation with, there are no prizes for guessing that the topic of my dissertation was reactive hypoglycemia. Professor Sayasakos spoke with an infectious amount of passion, while calibrating the detail and depth he spoke to the fact that I was just a third-year medical student at the time. Passion in teaching is massively underrated, and especially in the context of research, which can feel very intimidating to those at the start of their academic careers. I really do believe that research is an essential part of being a medic and a doctor, and that this exposure in my third year taught me that I did have the ability to understand a complex topic, become an expert in my own way, and identify problems, hypothesize, interpret pre-existing literature, all of which supports clinical reasoning and communication. I'm very, very grateful for the opportunities and the support that I had with Professor Sayasakos, and I do attest my clinical reasoning and communication skills to him, and I hope I can speak with a similar amount of passion when I'm an expert of my own. Being challenged by my mentors. I think this last point may not apply to all students, and I can only speak for myself and my own experiences. I personally loved being around doctors of all grades who challenged me and turned my time on the ward or in clinics into an opportunity to learn. Better still were those who not only asked me questions, but took it a step further and asked me why, or continued the line of questioning until I reached a point that I did not know. I think progressive questioning is really important for several reasons, and my experience with that was particularly helpful in the Viva. It tested if I actually understood the reasons behind the answer I was giving, and linking back to the first point of supporting understanding and having long-term knowledge. It taught me what I didn't know, and supported me to be aware of my limitations, not only as a student, but now as a doctor as well. When I didn't know something, it forced me to try and make connections with knowledge I already had and make an educated guess or suggestion, rather than simply saying, I don't know. it also made me more comfortable with not knowing something and being able to admit that I don't know and perhaps need to pursue further knowledge. And working in the unknown is, I think, a reality of medicine given its breadth. And I think getting students who are often perfectionists comfortable with this idea that they have limitations and don't always know anything is incredibly important, and there's no weakness in it. I think there's increasingly concern about testing or challenging students, and truthfully, not everyone likes that approach. Since graduating, I've had students of my own who I teach, and I always try and ask what they find helpful. As far as I know, I've not upset anyone, but I have received some really fantastic feedback with this kind of progressive, more challenging approach, and I think it does create more clinically confident junior doctors. I'd just like to take a moment to really thank everyone for the experiences that I had, not only at UCL Medical School, but specifically at the Institute. It's been a really fantastic environment to learn, and I feel incredibly drawn back here always. It really does feel like home, and I think it's an amazing place to learn. A special thanks to Miss Witten and Professor Sayasakos, who have been brilliant mentors. But thank you very much for your time.
So thank you so much, Salsa. That was wonderful, lovely. Does anyone have any comments or questions that they would like to ask for Salsa?
I did a good job.
Good, you did a great job. Okay, well done. Thank you very much.
Thank you. Well, congratulations, everybody. You've nearly made it. Coming up is the photo opportunity and the drinks reception. My name's Stuart Lavery. I'm Divisional Clinical Director at the Trust for Women's Health. And it's a real privilege and pleasure for me to close the meeting and to announce the prize winners. And also to say thank you. Some people have worked incredibly hard behind the scenes to put this together. We also need to say thank you to all the speakers, and thank you to all of you for attending and for engaging in the meeting today. So, the Institute represents the very best of the partnership between the university and the hospital. And it really is testament to the vision that Charles, that Anthony, and that all the directors that we heard from this morning. And I think today's experience really lives up to that ambition. So let's hear about the prizes. This is an announcement of the prizes as opposed to an award. You will all be receiving the awards by email next week, I'm assuming. Okay, so the prize for the best oral presentation, the medical student prize talk, goes to Meghna Balakrishnan for female fertility preservation in a primary brain tumor cohort. Well done, Meghna. For the oral sessions in session 1, our prize winner... Oh, sorry. Don't you just love PowerPoint? Okay. We've got it here. It's coming now. That's all right. We need to think on our feet and not panic. I'm delighted to announce that the runner-up is Georgina Murray and Sophia Mastromano for antenatal care and management. And our first prize winner is Raymond Pang for efficacy ranking of cryoprotective therapies. That's okay. We can therefore announce that for the session 2, our first prize winner is Zonglin Lee for early detection of ovarian cancer. And our next prize is to Dan Riesel and Serena Dwyer for using AI to deliver clinician-validated information. No? Okay, I'm going to give up and we'll stay going live. It's like live TV. Okay, so the winning posters. Best Medical Student, Babita Panesar. Best MSc Student, Penny Chamberlain. Best PhD Student, Freweni Tesfaye. Best Clinician Stroke Researcher is Iona Evans. Best NHS Audit QI Poster is Halima Alazani. And the best overall poster is Juan Antonio Diaz. Okay. That's all right. There we go. Okay. So the drinks reception is held at the map here. All of you will remember the photos that all the directors put up earlier. This is your chance to be in that photo that you can show next generation. So please don't leave, but put your best smile on, your best lipstick on, and your smartest shirt for that. I'm just going to finish by saying that I'm sure most of you have had a classical education, and you'll be aware of the Roman god Janus, who was the god of beginnings, transition, and endings. And he had a face that looked backward into the past. And I think we can look backward with some pride of the legacy that the Institute has had over the last 20 years. But he also had a face that looked forward to the future. And listening to the early researchers today, boy, what a future we've got ahead of us. And I think a combination of the energy, the innovation, and the ambition of all of you in the room, coupled with the leadership of Anna, means that the Institute is in very safe hands for the next 20 years. So thank you. And Anna will now lead in the photograph direction.
So Ian, very kindly, is going to come up and take the photo. If anybody's out the back there, please do come in and fill up the room. So we'll just give it a few more minutes for people to come through. There's spaces, there's chairs here, spaces at the front, so come forward. Come forward and fill up the gaps. Can you turn off the projector? Thanks. We're just moving the 20-year balloons to the back. So if people can come forward, take a seat. We've got plenty of seats at the front. That's it. Come forward, Peter. Brilliant. Martin, come on. We need you at the front. You've got to come, come on. Yes, you. I'm talking to you, Martin. Thank you. Excellent.